In our last lesson, we looked at the right heart using point-of-care ultrasound and saw what a right heart should look like with normal anatomy and function, including the windows of the apical four-chamber view and the peristernal short-axis view. And then we started to look at some pathology of the right heart, including right heart strain, and what some of those findings might look like on ultrasound. Today, we're going to focus on a short lecture that covers some of the other things that we might see when looking at the heart using point-of-care ultrasound. First up, and quite importantly, we should be able to identify large pericardial effusions, particularly those that might lead to cardiac tamponade. Because pericardial effusions can come in all shapes and sizes, if it's large enough, you should be able to see it on any view. However, the two views that I want you to use to get in the habit of using at least when evaluating for a pericardial effusion on ultrasound are the peristernal long axis views and the subxiphoid views. On the peristernal long axis view, the pericardial sac appears as a highly echogenic structure that surrounds the heart and the proximal aorta and pulmonary vessels. You can see that here. Pericardial effusions are going to look like dark anechoic collections of fluid, for the most part, that accumulate posterior to the left ventricle and will track anteriorly over the descending thoracic aorta, which I've highlighted here. On a peristernal long axis view, we can clearly see that there's a collection of hypoechoic or anechoic fluid right here that does indeed track over the descending thoracic aorta seen here. So this is evidence of a pericardial effusion in the long axis view. The subxiphoid view takes advantage of the liver as an acoustic window to be able to examine the heart. And this is the view that we'll use in our FAST exams when looking to see if there could be evidence of a large pericardial effusion that may need to be drained if a patient is in shock. In this view, we see the liver in the near field of the screen, and then we start to lose that hyperechoic pericardial line and diaphragm because there's a collection of fluid here that indeed is affecting the right side of the heart. So this is another pericardial effusion. In cases of traumatic hemopericardium, we sometimes are able to see a hematoma forming. Here we see a collection of fresh blood, which looks anechoic, as well as some coagulated blood, which takes on a nearly uniform sort of isoechoic gray texture. And so this would need to be surgically drained for this heart to be able to return to normal function. Every now and then we can also get an infection of the pericardial space. So here we see what a purulent effusion might look like. And you notice that there's some loculations here, some septations within this fluid, as well as heterogeneity within the fluid itself. And this is again a subxiphoid view. This is another special type of pericardial effusion that I want you to be familiar with, which is called a fibrinous pericardial effusion. And it's named so because you can see that this fluid surrounding the heart has these little tendrils up here of fibrinous material. And this is a finding that we see oftentimes in the global health setting in patients that have tuberculosis with a cardiac manifestation. However, in more developed countries where tuberculosis is not as endemic, we often see this in malignancies, in severe cases of uremia, in like our compassionate dialysis patients, and in cases of connective tissue disease or lupus. It can also be seen in post-traumatic or post-operative states, although that's pretty rare, especially with the advent of less invasive surgical techniques. Now, effusions can become even more distressing when we start to see evidence of cardiac tamponade. So as pressures inside the pericardial sac rise with accumulating fluid, the pressure in the right heart can sometimes be exceeded by the pressure inside the pericardial sac, and this can lead to cardiac tamponade. The sonographic evidence for this is right ventricular free wall collapse, which is first seen during diastole when the mitral and tricuspid valves are open. So this is a peristernal long axis view. We see here our right ventricle at the top of the screen. We see our left ventricle here at the bottom, the left atrium here, the mitral valve opening. And we see definitely a pericardial effusion because it's tracking anteriorly over the descending thoracic aorta. But at the top of the screen, we see this both in real time and then in a slightly slowed motion. You can see that this ventricular free wall collapses. And that is pathognomonic for cardiac tamponade. And it's important to remember that cardiac tamponade is not necessarily dependent on the volume of the fluid inside the pericardial sac. It's dependent on the pressure. And so even with small effusions, you can get tamponade depending on the pressures that are being generated. Here's where that free wall collapse is occurring, just highlighted for you. So there's a few things that can mimic pericardial effusions that I want to go over as well. The first is a pericardial or an epicardial fat pad. So because this is an organ that slides around in the chest, slides over the diaphragm, oftentimes patients will develop a small little cushion of fat that can, in certain scenarios, take on the appearance of fluid. Now, to confidently say that a hypoechoic or an anechoic area is a fat pad and not a pericardial effusion, we should see it over the right ventricle, and especially in the atrioventricular sulcus. It should not change with position, so if you put the patient in a different dependent position, that hypoechoic area should not move. The pericardial effusion should not be present in other views. So if you see a pericardial effusion in your long axis view, for example, and then you go to the subxiphoid view and you see this, that's something that you need to investigate with a formal echo. You can't just rule it out. And then every now and then you'll see that these findings are a little bit more echogenic. There is enough structure inside the fat to make it slightly brighter than just a complete fluid collection. However, if there's any doubt, my encouragement for you would be to evaluate all of these findings with a formal echo just to be very sure that there's not a pericardial effusion that needs to be dealt with. Another finding that can sometimes be present is fluid in other spaces outside of the pericardium, but close enough to the heart that it suggests that there might be a pericardial effusion without closer investigation. So here we see an example of a pleural effusion that at first glance might be mistook for a pericardial effusion. However, we can see that this collection of fluid stops without tracking over the descending thoracic aorta here. We also see a calcified little mitral valve right there that's kind of blocking some of this view. But because it's not tracking, it's likely to be in the thoracic cavity above the diaphragm, but not inside the pericardium, and not a pericardial effusion itself. So similarly, on this subxiphoid view over here on the right, we can see that there's a lot of fluid in this area, but that the heart itself seems to be maintained within the pericardial sac, and this is actually intra-abdominal free fluid or acidic fluid. And we can know that because this connection here is actually the falciform ligament of the liver connecting up to the diaphragm itself, and then this collection of free fluid is below the diaphragm or closer to the probe in a subxiphoid view. So these are things that you would probably see a positive FAST exam on and might take other windows to look at, but it is important to be able to remember your anatomy and remember the findings that are consistent with pericardial versus pleural or intra-abdominal effusions. Another thing that sometimes we want to look at within the heart is the valves. However, and you thought you were going to get away without this slide, but no, it's going to be in every lecture. Remember that POCUS is a tool to answer a focused clinical question and not a full imaging study. That being said, POCUS is not geared for big valvular pathologies. So if you happen to see valvular pathology incidentally, that's an indication to go ahead and proceed with a formal echo. Valvular pathology, when it is present, generally comes in one of three different flavors. Let's go over them. First up is valvular insufficiency. Basically, that's when the valve ain't closing right. And so with these, you start to get regurgitation, which can often be seen on color flow, and will result in the upstream and downstream chambers being dilated due to passing of fluid between the two without it being ejected forward. The second of these three flavors is stenosis. The valve ain't opening right. So here we see a short axis view, a peristernal short axis view of the aortic outflow tract, and we see that those little Mercedes-Benz sign of the aortic outflow, the aortic valve, just isn't opening briskly. Those cusps are just barely spreading apart. They're not slamming open and basically touching the walls like we would normally see, and this can be an evidence of a stenotic valve. And then the last of our three flavors is structural pathology. Basically, the valve ain't supposed to look like that. So in this peristernal long axis view, which then is rotated to a peristernal short axis view, we can see that the mitral valve, instead of being nice thin little lines that are flapping in the breeze and high-fiving the intraventricular septum, they've got these big old goombas attached to the atrial side of the mitral valve leaflet. And indeed, these are valvular vegetations in a patient with endocarditis. Another question that I get asked a lot about for point-of-care ultrasound is using that to screen patients who might screen positive for hypertrophic obstructive cardiomyopathy based on history or physical exam. Let's talk about why this is a problematic use of POCUS. So despite its clinical significance, there are currently no well-established guidelines for screening for hypertrophic cardiomyopathy with echocardiograms. Cardiac screening in pre-sports participation exams varies depending on where you live and what your guiding organization is. Here in the United States, we follow the AHA-ACC guidelines, which recommend yearly pre-sports physicals with a targeted cardiac H&P, but do not include EKGs or echoes as routine investigations for all athletes. In Europe and in the international and Olympic organizations, including FIFA, they do include screening EKGs as routine, but there's no major organization that currently recommends or mandates an echo. Now, here's one study that I found that looked at just over 2,000 athletes using medical students who screened for hypertrophic cardiomyopathy by giving them all a screening echo, and then went on to confirm whether or not hypertrophic obstructive cardiomyopathy was indeed present with a formal echo. But you can see that of their sort of protocol, 171 patients screened positive, while only 7 of those 171 patients actually had a confirmed HOCM. And so this is a challenge, because even pretty well-designed studies that look at protocols where we could be screening result in a lot of patients that are going to go get a additional imaging study that might not need it. And so for this reason and others, this is probably why it's not currently recommended as routine screening. Here's a couple of examples of what this does actually look like on ultrasound. So here we see a peristernal long axis view of the heart, and we see that mitral valve leaflet. Typically, as it goes up and slaps the intraventricular septum, it has to traverse a pretty far distance. But here we can see that there's actually thickening of this intraventricular septum in this pattern right next to the aortic outflow tract, which is pathognomonic for hypertrophic obstructive cardiomyopathy. And indeed, as this ventricle contracts, you can see that there is a close approximation due to systolic anterior motion of the anterior leaflet of the mitral valve that could, in the right patient, obstruct the outflow of that ventricle. One of the screening protocols you might sometimes come across is doing this thing where you use the M mode to measure the distance and shortening across the ventricle. And it's a thing that you might read about, but it's not a very specific way to evaluate for this. So just know that that's something that's out there in the literature, but that the evidence doesn't support its widespread use just yet. Lastly, I want to go over how we can use point-of-care ultrasound for code blues, which is our code in the United States, at least, for a cardiac arrest occurring inside the hospital. Why should we use POCUS during cardiac arrest? There's a few reasons. The first is that sometimes POCUS can identify shockable rhythms that are not being picked up by a cardiac monitor. I'll show you an example of this in a minute. It can also direct early procedural intervention by helping identify cases where there might be a pericardial effusion that needs to be drained in tamponade, for example. It can also expedite surgical management if we see that there's a large abdominal free fluid on a positive fast exam. Then we might try to stabilize the patient and understand that they're after resuscitation, they need to go to the OR to prevent repeat cardiac arrest. It can also be of prognostic value, especially as an adjunct tool to help us decide to end resuscitative measures in cases where it might be futile. Now, all of these are expert level opinions and expert level evidence and recommendations. So there's no large, well-designed studies that have shown evidence that change clinical outcomes. However, if you have a big team, you have plenty of people on hand to provide this care, ACLS does indeed include this as adjunctive care that can be considered during a code. So let's go over a case real fast. Here's a code blue of a 38-year-old male that was found down and brought into the emergency room by EMS. They have been doing CPR for 15 minutes. They have been placing an AED in place, which is reading as asystole and no shock advised, and so they've continued several rounds of CPR now. Throwing an ultrasound on this patient, we can actually see here in the subxiphoid view that if you look very closely, this, especially like at the intraventricular septum and the ventricular free wall down here, that there's actually very fine movements of the heart. And this is actually a case of ventricular fibrillation. And this very fine VFib is a shockable rhythm. And so this patient, the management would change because you might be able to shock them and get them out of this VFib rhythm and potentially resuscitate them. Now here's an almost identical case. 38-year-old male found down, CPR has been in place, and then AED reads asystole with no shock advised. But here we're using our point of care ultrasound exam to take a look at the heart using M-mode, and we see that there's essentially no cardiac motion whatsoever during the pulse check. And so this is called cardiac standstill, and of the few documented survivors of cardiac standstill, there have been no reports of a neurologically intact survivor. So this could help us determine that in this case, this patient has probably sustained a terminal injury where resuscitative measures would not be clinically significant or meaningful, and it might be more compassionate or ethical for us to de-escalate and allow the patient to pass peacefully. So some common pitfalls for using POCUS during cardiac arrest include that the windows that you can use are basically limited to the subxiphoid view. You can't get in the way. If they're doing chest compressions or needing to do a ER thoracostomy or something like that, that is something that we don't want to be limiting by trying to place our probe and get some images. This is not the time when we're going to be taking complex views, using ultrasound, the parasternal long axis view, and rotating to get all the views of the PSAX. No, we are just there to see if the heart is functioning properly or not, see if there's big effusions or not, and help determine rhythm when we can. This is a time-sensitive exam, so this is something that the most experienced provider with point-of-care ultrasound should be performing in these settings, or at least on hand to help direct learners. Also, this is something that a lot of people don't think about, but you can't use too much gel, especially on the chest itself. And the reason for that is because if this patient is going to get shocked, ultrasound gel is able to conduct electricity. And so it can actually, depending on how much gel is on the chest, can disrupt the normal electric flow of the electricity through the patient's heart and body, and instead direct it through the skin and through the gel itself, which will eventually result in ineffective defibrillation. So something that's kind of a unique finding. The other thing is that sometimes things like valve motion or respiratory motion of the heart itself can cause a mimic effect of what myocardial motion might look like. So someone may actually be in cardiac standstill where we should probably not be proceeding with resuscitative efforts, but really the motion that we're seeing is artifact due to still moving fluid in the body, respiratory motion, swirls and bubbles from pushing IV meds, and it's not actually due to myocardial contraction itself. And then sometimes there is unfortunately a delay in calling or draining a tamponade when we use POCUS because we hesitate to confirm it and we don't want to make the call that, hey, it looks like there might be a pericardial effusion. But in any unresponsive patient that has a detectable pericardial effusion and is otherwise being coded, that patient needs to presume that there's a tamponade there until proven otherwise. So go ahead and call those, and don't try to get ventricular free wall motion and that kind of stuff. Just say, hey, no, there's a big pericardial effusion. This patient's coding. We need to escalate care. So in review, we talked about some of the finders of pericardial effusions and some of the mimickers that can demonstrate fluid around the heart, but not necessarily within the pericardial sac. We talked about how to diagnose cardiac tamponade using sonographic evidence. We talked about what you might see if there's some valvular pathology and reminded you that, hey, if you do see something, that's a case for a formal echo to further evaluate. We talked briefly on hypertrophic cardiomyopathy and cardiac screening for pre-sports participation physicals. And we've also talked about the use of POCUS during code blues and why it might or might not help change your management. So with that, that's the end of our cardiac POCUS module. I hope you enjoyed it and learned something new and are anxious to get your hands on a probe and start scanning your patient's hearts. Let me know if you have any questions. Drop a comment in the box below. And otherwise, we'll see you in our next module.